In 3, 2, 1.
Hello and welcome to the national webinar series on Discharge to Assess. My name is Callum McGregor and I'm an Improvement Manager with the Emergency Care Improvement Support Team. Along with our national discharge partners, we've got Local Government Association and the Better Care Fund team. We have designed a series of webinars and today is number 3 in the series of 7 on Discharge to Assess. Today's webinar will focus on the data, so I have 2 of my colleagues with me from ESIST who are going to go through what data is collected, what that means for you as a system and how you can use it to improve discharge to assess for all the health and social care systems across the country. Looking at today's agenda, we have my colleague Chris Green. Morning, Chris.
Hi Lee. Hi everyone.
And we have Lee Forsyth.
Morning everyone.
Hi there. So Chris and Lee are going to go through a presentation which should take about 20-30 minutes and then that should leave about 20 minutes for question and answers. Just in terms of housekeeping, once again, this is an MS Teams live event and so all participants will be muted on arrival and so you won't need your cameras today. If you can post any questions you have for both speakers, or we have a couple of panellists. We have Rosie Seymour from the Better Care Fund team and Philippa Lynch from the Local Government Association. So if you have any questions for speakers or panellists, then please post them into the chat room and my colleagues Helen Bennett and Angela Bullivant, along with myself, will do our best to theme those questions and pose them to the speakers and the panellists. As always, we are recording this and we will provide the link as soon as we have it, probably in a couple of days' time. You will all receive slides as participants to this and you can share those with your colleagues. We will have details of the further 4 webinars towards the end of today's programme. So I will hand you over to Chris for his presentation. Thanks, Chris.
Great. Thanks very much, Callum, and welcome and good morning, everybody. It's a pleasure to speak to you today. So as Callum said, my name is Chris Green. I am the Head of Informatics for the Emergency Care Improvement Support Team at NHS England and Improvement. And in short, my job is to kind of look at anything to do in terms of data and analytics for anything to do with urgent emergency care. I've worked in a number of organisations around the country and been with ESIST now for around about 5 years. The interesting thing over the past 6 months is obviously we've all kind of adapted our roles, and so over the past 6 to 7 months I've been helping out with a lot of the long length of stay, the discharge work, and also some of the national COVID teams. And what I'm going to be doing today is I'm going to be talking about how data and information can be used in order to drive conversations. And Lee and I will be kind of dovetailing. So I'll be talking about what the data means, and then Lee will be talking about some of the ways in which the data can be used. If we could just go on to the next slide, please. So as many of you will be aware that we're living in unprecedented times, really, and I'm going to be talking about it slightly differently. So I'm going to be talking about it in terms of what we've been seeing through the data. And data always should only ever reflect what people are going through. So frontline staff, clinicians, operational teams, the data should really only ever be reflecting back what is actually going on in frontline patient facing people. And we've never seen such variation, but the data doesn't just happen. Okay, so it's always because of something. It won't just naturally occur. And what we saw certainly during the first lockdown, obviously this talk is well timed, that we saw significant reductions in attendances, particularly from the first lockdown date of March the 23rd. But we also saw significant reductions in other areas as well. We saw significant reductions in occupied beds, particularly around long length of stay patients, reduction in ambulance handovers. And what we wanted to kind of talk through today is actually how these various metrics link up, and not just focus on the acute setting, but also look at how data can be looked at in the ways in which system improvement can take place. Let's go on to the next slide, please. So I just kind of wanted to show you two maps that probably a lot of people will have ordinarily have seen, but I just kind of wanted to put this into a little bit of context. And The interesting one is that data is used, I'm sure that many of you will have seen the Prime Minister's briefing on Saturday, where data can be used in multiple different ways. And what I try to do is I try to present data that can be easily understood, and it provides some kind of clarity around improvement work that is taking place. Now, these two graphs are taken from the ESIS dashboard, which comes out twice weekly. This is from the national one, and what you can see, and I'll draw your attention to the graph on the right, the map on the right hand side, is this is county level proportion of beds that are occupied by COVID positive patients. And the reason why I wanted to kind of illustrate this is because a lot of people are like saying, oh, why should we have national lockdown? And you can kind of see that, particularly in the northwest and the northeast, there are significant proportions of beds occupied by COVID positive patients. But actually, if we look on the map on the left hand side, that actually the bed occupancy is actually higher in the Midlands and in the southwest regions. And so what we have to kind of do is we have to use data to try and understand what is going on across all organisations and systems. And that's really something that is quite important to do, that most people try and isolate and take data down at such a granular level that it doesn't provide any level of clarity. But what we need to do is we need to look at good quality data analysis so that we can actually make significant changes. And the role of any good analyst is that they provide the level of detail that operational and clinical staff need to do to promote good quality patient safety. If we go on to the next slide, please. What I then wanted to do is that in the NHS, we're absolutely fantastic at looking at one metric in isolation. So, particularly, if you go back kind of 3 or 4 years, the one thing that people have been looking at is around the 4-hour standard, for example. But what we want to kind of understand is, well, actually, is there a relationship between the proportion of patients that are discharged and it goes on to, the flow through the acute setting, going on to community care, social care, etc., etc. And what I want to draw your attention to is that people often focus at the front door of when patients come through the hospital, but actually it's incredibly important about what happens to the patient when they're in hospital, what they're waiting for. And that's certainly something that I'll be coming to talk about in a few minutes' time. But what we can see from this graph is that I've got 4 lines on here. I've got the number of beds occupied. I've got the number of beds occupied by patients with a long length of stay of 7 days. Number of beds occupied by patients with a length of stay of 14 or plus days. And then lastly, the number of beds occupied by patients with a length of stay of 21 days or over, or the extended length of stay patients that has been known for the past few months. And what we can see from the red line is that all of these lines are going up. OK, so as I said, the reduction that happened around March, the latter part of March, going into April and May, which was significant. We've seen a steady increase in those metrics ever since. And we can certainly see from kind of August time that all of the metrics have been increasing. But the reason, if you put them all on one graph, what you can clearly see is that, yes, the red line, which is overall occupied beds, have been increasing. But what we can see, which is much more important, is that the rates of change for both the blue line, the black line and the green line have been increasing at a higher rate. So particularly for the long length of stay patients with a length of stay of 21 days or more, these patients are not only spending longer in hospital, but they are growing at a greater rate than the rest of the occupied beds. So should we be focusing our attention on one particular area, or should we be focusing our attention on another area? And that's where we kind of want to get to, is that actually you can focus on what's happening at the front door, but if we're keeping more patients in hospital for longer, that we did see a significant reduction of around the early parts of April and May, that is something that we should be focusing our attention on even more. If we could just go on to the next slide, please. And then not only can we kind of see that things have been going up and things have been going down, but what is really important to do is to try and understand where the variations are, and try to understand that the beds are not available at the right time. And what we can see is the graph on the bottom left is a hospital that we've been doing a piece of work for over the past few weeks to try and understand when they have a net impact of their discharges through the day. And so what we've got is we've got the graph starts off over on a Monday morning at midnight and goes all the way through to the Sunday. And this is kind of an average over the, well, it takes a median of every hour of every day over a 6-month period. And what we can quite clearly see is that they don't have a net deficit of their beds until around 5, 6, 7 o'clock in the afternoon. And the challenge for this particular organisation was they were seeing a significant increase in their long length of stay patients. And not only that, but those long length stay patients, when they were discharged, were all discharged late in the day. And they didn't understand that. It was one of those things that they came to me with a question or the ask to kind of say, right, well, we need to understand the flow of patients through our hospital, particularly around our complex discharges. And what we were able to do is we were able to ascertain it's from the data that they were able to provide us and the level of granularity that we could get through other sources, was to try and understand exactly the pathways of these patients going through, where they were going to, which is the really important thing. Because historically, what organisations such as this one, they self-confessed, was they were just looking at raw numbers. They were just saying that X number of patients were being discharged, and out of those, a proportion of those were long length stay patients, but they weren't really understanding what pathways they were going on, where the patients were going to, and whether that external organisation had the right capacity to do that. And then if we have a look over just on the bottom right hand side, we can just have a look at the admissions and discharges by day of the week. And this is a really, really standard profile. So if we did this for almost any organisation in the country, you would see that the admissions profile is relatively similar through to Monday to Friday, with a tail off on Saturday and Sunday. But the discharge profile is significantly different, with a higher rate of discharges on a Friday and a lower rate of discharges on Saturday and Sunday. And I've probably done this type of analysis for around about 55 to 60 organisations over the past few years. And this is a very standard picture. And in fairness to this particular organisation, I would probably say that this level of discharges at the weekend is not necessarily bad. I've seen substantially worse organisations. But what they weren't able to do is they weren't ever able to quantify that, because they didn't just look at it in a certain type of way, and they didn't understand the question they were trying to ask. And that's a really important thing for us, is that you need to understand what the ask is. I had a call with an organisation today, and it was a whole system. And what we wanted to try and understand was that where are these patients going to? But what they couldn't understand, what they couldn't work out, was they couldn't work out the ask, the question that they were trying to solve. But because we went through that with them, created an exam question, they were able to clearly articulate what they wanted to do, and we could piece the data behind it to help support their case. Can we go on to the next slide, please? And really, the NHS over the past few years has been a self-fulfilling prophecy, because we've been seeing more patients come through the front door with a reduction in capacity, and both that in terms of staffing and in terms of physical space as well. And then the lack of understanding about where the patients are going to, and the difficulty in trying to provide good quality analysis and data to work out the rest of the system capacities. And realistically, what we've been seeing is this higher number of patients in the emergency department, which leads to queues in the department, which leads to poor quality care and an increase in ambulance handovers. Then it leads to an increase in the amount of time that it takes to be seen by a senior clinical decision maker. Then we see that higher propensity to admit, and therefore they'll kind of say, well, if there's not a medical bed available, let's just put them into any bed. And so that we have a higher propensity to have an outlier. We then know that the outliers in a medical outlier in a surgical bed have a higher length of stay, which then leads to higher levels of occupied beds. And it's a self-fulfilling prophecy, because where do you draw that line? Where do you break that cycle? And that's the really important thing to try and understand, is what is the ask and how can we try and solve that? So what we've been doing, and if we could just go on to the next slide, please, is through these new data collections that every organisation in the country has had to complete. So we are acutely aware that over the past 3 to 4 months, that additional data requests have been issued both out to acute and community providers to try and understand what is going on at a granular level. So not just looking at the raw numbers, not just saying that an organisation has admitted 85 patients, and that is statistically significant. But more important to understand, what are the patients in hospital for, what are they waiting for, and where are they going to? And so the new COVID collection, which you'll probably all be familiar with, is something which has provided that greater granularity. There have been issues with that, and I think that is well known, is that the data quality behind the collection is not where it needs to be. It is substantially improved from where it started off, which has been a fantastic achievement by all those people concerned, and we would certainly like to thank the acute and community providers in providing that level of granularity. But what we wanted to do was, it's all well and good capturing that data, but it's really important to present it back to organisations so that they can see where they are in terms of other organisations, so where they can have a look at their data quality, where they can have a look at their performance around this particular type of thing, so that it can help drive improvement. So this dashboard, which comes out on a daily basis, it comes out from myself, but there's also other ways in which this data can be disseminated to people, is a way in which that you can have a look at the criteria to reside, for example, at the graph in the top left hand corner. And what you'll notice is you've got all of the reasons there. So are the patients waiting for physiology, treatment, recovery, function? But what we can then see is you've got 3 bars within each of those areas. And those 3 bars are, the blue bar is the organisation that I've selected. So as a random example, I've just selected the James Paget Hospital in East of England. The blue bar will be that selection. The orange bar will be the region, so you can see how that directly compares with the region. And then the grey bar is the rest of the country, so that we can just understand exactly where an organisation is in relation to the rest of the region and the rest of the country. The challenge around that is, and I'll be really clear about this, is that we don't necessarily advocate benchmarking unless you can identify the peer group that you want to benchmark against. So just saying that you're going to benchmark against X organisation or Y organisation, you need to understand the makeup of those patients so you can directly compare like for like. So on the left hand side, we've got the criteria to reside, and on the right hand side, we've got the discharge destination. So once again, we can have a look at why the patients are in hospital and where the patient has been discharged, where they have gone to. We've got this for both the acute COVID daily data collection, and we've also got that for the community daily data collection as well. Once again, they are available. I'm happy to include anybody else on those data daily emails. If anybody would like access to them, then please feel free. And I believe my Lee and myself, our contact details will be made available to anybody. So that's it from me. Thank you very much. I'm happy to take any questions, but I believe we're going to do that at the end. And I will now hand over to Lee.
Brilliant. Thanks, Chris. So I think where I'm coming from is to try and do a bit of a canter through what this might look like in a real system, just how it applies in the real world. So I think most people have a good understanding of data itself, and quite a few people have a good understanding of measurement for improvements. So it's really trying to understand that variation. But I think where the challenge is how we apply those skills in the real world, because it's one thing seeing that, having the theory, it's another thing actually trying to do it in the real world. So I'm going to try and go through a system now with some of this information, and just to start thinking about some of the hypotheses, and then we'll finish with just signposting to a few more resources. So next slide, please. So I think quite often people are presented with data such as this. So the 21-day length of stay in this particular area is 21.94% and is rising, which begs a number of different questions. Next slide, please. And so what I'm trying to do is try and go through some of the information around this. So quite often what we hear is actually we've got increasing people coming through the front door in the first place. So when you actually start applying things like statistical process control to data, you can start seeing that actually this particular system is pretty stable. There might be a bit of a shift developing towards the end, but ultimately it's a pretty stable picture. Next slide, please. When you start looking at the conversion rate, because people say, well, actually we might get more complex people through the door. The conversion rate here suggests that actually there's been some variation. There's been some periods of positive and negative shifts within here. So there's possibly an issue around some of the variability on a day-to-day and week-to-week basis. but ultimately it's pretty stable within this. And next slide, please. Simply around the ambulance attendances, which I know is not necessarily a perfect indicator for level of complexity and is fraught with all its own issues. But I think I want to come back to Chris's point he made earlier on. Actually, we can't, data won't necessarily give you all the granularity you want to ask of a particular question. And things around identifying what are these indications that's going on in the system that you can then look at in more detail and start getting some of that information in more detail. Next slide, please. So when you start looking at the 7-day length of stay in this particular organisation, so you can start seeing actually it is beginning to rise from around about the start of September. We're really seeing quite an increase numbers of people staying for those 7 days, but it does sort of plateau after that. What you do find is also when you start looking at data in detail, you start seeing a weekly pattern emerging, with drops present most Fridays, which is that high level of discharge rates happening on a Friday, then the numbers of people building up again over the weekend. So from an operational perspective, you start thinking over actually what can we start doing to prevent some of these weekly patterns occurring? What sort of things do we need to start looking at on Saturdays and Sundays to help with that? Is that criteria-led discharge, 7-day services, getting some of the support services in place, such as equipment supplies, pathway 1 capacity, all of those sort of other questions can start building in your own head. Next slide, please. So then you start looking at a 21-day length of stay, and again, a similar sort of pattern starts emerging. And again, weekly patterns emerging with peaks present on Sundays, possible issue with the weekend discharges. It really starts sort of pulling out that actually the weekends are getting steadily more congested over the weekends. Although there is a general pattern, the weekends do seem to be a fairly significant problem. And although this week the 21-day length of stay was 21.94%, actually even the six week averages is still pretty high. And obviously the more patients, the more people with 21-day length of stays in the bed base, the higher impact it's going to have on the overall occupied bed days. Fairly disproportionate effect. Okay, next slide, please. So when we start looking at this as well and start using some of the control limits on it in a bit more of a nuanced way. As we know within the system, there's a change around about 23rd of September. And then we start recalculating the control limits on there. And why is this important? So the control limits will give you a really, really good indication of where normal variation exists within your own system. So in this particular system, the control limits are set between around about 20 to 25%. So what we do know, Andrew, you're not going to get unless something substantially changes within this system, you're not going to decrease the long length of stay patients lower than the 20%, which is fairly significant if you actually have got projections or trajectories based upon a percentage occupancy. Because as I said, you do need to do something fairly significant. It's not just going to happen by chance. You do need to make a significant change to this whole process to achieve that level. And quite a lot of the country are aiming for around about 14%. So this particular area has got a high proportion in there. Okay, next slide, please. What we do is beds occupied. Again, similar sort of time they're changing. It seems odd that the beds occupied are so stable, given what we do know and what we've seen in with the rest of the numbers. Okay, next slide, please. And this is where it starts when we start looking at occupancy. Again, it suddenly gets very, very stable from that particular area. And what was being reported for this particular area was that the occupancy overall was around about 78%, I think it was. And it's very, very stable. And given the increasing proportions of 7 and 21 days, you start thinking, what's going on with this particular area? And as it's spelled out, there's the denominator, so the overall bed numbers they were using for this hadn't been adjusted for infection control measures. So straight away, you can actually see that this plateaued. The data didn't really make sense. So just by quizzing the data in a slightly different way and asking slightly different questions, we were able to flush out what the actual true issue was around this one. Next slide, please. And as Chris was saying, the criteria to reside is really useful new data collection to start understanding, well, actually, what have we got in there, what's going on. So I've included this not so much because for the detail, but more to say, actually, we know that data quality in this particular organisation wasn't too bad. I'm sure there's a whole myriad of other issues underneath it, but on the surface, it appears not too bad. Next slide, please. What we do see though from here, so there's some fantastic stuff. About 90% of people going home. Also the fact that they've identified about 125 people per day who did not meet the reasons to reside, although very, very low numbers were actually going home. So only about 8% of those people were actually going home. So then you start thinking about actually, well, why is that? What is this? Is this a particular blip? Because obviously this is a daily collection. So next slide, please. And actually, apart from one day where I'd suggest that it's more of a data quirk, a data counting error rather than anything else, it's actually a pretty similar level. So if you're trying to think about it, it's not an operational level, you need to start thinking about actually, well, what's going on between the board round and trying to get people home by 5 o'clock? Are there some problems there around things like discharge letters, TTOs, transport? Is it something around communication to the ward staff? Is it around the timing of the board round? If the board round's happening about 2 o'clock in the afternoon, it gives you a very narrow opportunity to actually get that person out of the bed before 5 o'clock. Are we using EDDs within this particular area to try and have a time that everybody's being G'd up to actually try and get that discharge happen at that particular day? Or is it just a similar thing like communication to the wider ward teams? So it starts leading to a number of different questions. Okay, next slide, please. And what we do have now is a weekly data collection. So what we'd hope from this particular data is that you start putting some visibility over some of these issues. Next slide, please. But what we do see is by using slightly different measures. So this is a Pareto chart, which you can start paying attention to the vital few rather than all of the different information. This particular trust was reporting high numbers around pathway 3 and pathway 1 availability. Pathway 1 you'd expect, pathway 2 is a little bit of a surprise, but I think that comes back down to the 21-day length of stay numbers in this particular area. If you've got high numbers, high proportion of your base being covered by 21-day patients, there probably is going to be a high level of deconditioning going on, which may well be driving the need for beds in there. But ultimately what we start hearing when you start talking to some of the clinicians, that actually there's also a lack of pathway 1 availability, which then drives people into pathway 2. So what I mean by that, there's a lack of community resources to support people being at home that is then driving a need for a community bed as the least worst option. Okay, next slide, please. So we start looking at the community. So we're actually what's happening in the community? Within the community sit rep data, actually what's happening there? Again, similar sort of thing. Actually, this particular area has managed to get the community sit rep ingrained really, really well. And had pretty good data quality. They're identifying high numbers of people that could go home, but again, similarly, only around 8% they could actually get out before 5 p.m. And again, from talking to them, they were really struggling to access the rearmament support, the pathway 1 support, to get them out of a community bed. There's a perception in the system that actually if somebody's gone to a community rehab bed, they didn't need rearmament at home, which is not the case. These people, if we're trying to decrease dependency and increase a much more of a pathway approach, there does need to be that step down process. So this then creating a massive backlog throughout the whole system. So actually the lack of pathway 1 capacity is beginning to have an impact both on the community beds and on the acute, in the fact that people can't come out onto pathway 1, but actually your pathway 2 access is blocked also from lack of pathway 1 capacity. Okay, next slide, please. And again, we get similar in this. And again, it's not a random thing. It was happening on a fairly regular basis and on a daily basis. They had that similar sort of access block, but fairly wide variation, which again in itself is going to cause problems when you've got wide variation between 1 and 8 people, which doesn't seem particularly big in the grand scheme of things, but in a small bedded area that can have quite a significant impact. Okay, next slide, please. And so I just want to sort of finish and said, hopefully that was helpful. I said this is a worked high level example. It doesn't tell you the whole picture. So just be mindful of other areas, things like elective activity. So this particular trust was actually holding their ED performance fairly well, actually, but that was at the detriment to their elective activity, and their elective activity was nosediving fairly heavily. Again, to reiterate what Chris was saying at the start, I think data will take you so far. It won't tell you the whole issue you need to tackle. But it will help provide several hypotheses to test. So when we sort of start thinking about actually, well, what are the ward processes from identifying someone can go home to actually getting them out of the door, there's a number of different hypotheses you might need to test on there. I think one thing we didn't actually speak around is the medical decision making. Actually, if we're identifying, we may well be identifying people too late as well. So there's a number of hypotheses to test at different places. And I think the process of testing these hypotheses can actually help provide a bridge across the clinical, operational and analytical teams. Because actually by combining the knowledge is only then when you can actually get a true understanding of what are the issues you really need to tackle. And I think with all of this, with looking at data, I always go back to the mantra of big eyes, big ears and small mouth. It's much easier to spot patterns that confirm what you believe, that confirmation bias, than something unexpected. And I think it's just being really, really mindful of what you look for in data and how you look at things. And then what I have done for the slide pack is just a couple of resources. So as Chris mentioned, there's a lot of analytic support and within our own team. There's not really good resources you can access through the link. Or if you're just interested in more the measurement for improvement principles, tools and resources, they include some standard templates like Pareto charts, funnel plots and bits and pieces. Then you can follow that link as well. And that's about it from me.
Thank you very much, Chris and Lee. And I suppose what we're really trying to kind of get the message across is that we want to use data for improvement. I know that when I was working on, so I'm a stroke physio by background, and when I was on the stroke unit, we knew that as a team, if we could discharge one person a day across our 2 wards, so we had 52 bedded stroke unit, so we had 2 discharges across both, that would be enough to keep our length of stay around 30 days. And at the time, this was obviously pre-COVID, that was enough to keep the flow going within the stroke unit and make sure that people got in from the hyperacute stroke unit into the stroke unit in good time and allow us to do therapy there and then. So it's really about knowing what data you have and what that means for your system. And you have to feed that back to the staff. They have to have visibility on what they're doing. So it's not just a kind of tick box collection process. It's actually about understanding how that means you can improve your system and your processes. So I'm going to hand over to Helen Bennett, who's going to be posing some questions to our speakers and our panelists. Over to you, Helen.
Lovely, thank you guys. Okay, so I'm going to start with questions for Chris initially and then moving on to Lee and the panel. So Chris, just going back to some of your earlier slides, can you just talk through what the current levels are of occupancy and length of stay and how they compare to pre-COVID ones, please?
Yeah, I can. The best place to get that from though, so if you just bear with me 1 minute, we are, in terms of COVID patients, you know, I'm just going to be kind of pretty much reiterating what was talked about on Saturday, but the current level of COVID patients is higher than it was at the peak. The challenge is that as that map that I showed you is that it's not equally spread across the country. So for anyone who's in the current northwest northeast position location, that there is a much higher level of COVID patients in hospitals than have historically been. But that kind of goes down when you go to the Midlands and Eastern London and South East, South West. In terms of overall bed occupancy, that's the challenge. So whereas during the first lockdown, because you saw that reduction in attendances, and then the natural progression was we saw a reduction in admissions, both in terms of emergency and elective care, we saw a reduction in occupied beds. At the minute, that's not happened. So our levels of occupancy are almost back to kind of pre-COVID positions, which is obviously not a good position to be in. But all those data points are on the ESIS dashboard, which I talked about earlier. There have been a couple of questions regarding access to dashboards. If my email is not on there, my email is chrisgreen@nhs.net, and I'm more than happy to have anyone request any access to either the ESIS UEC dashboard or the COVID discharge dashboards that I presented on earlier.
Thanks, Chris. And actually, just on your dashboard, you're right, the people have been requesting how they get access to that, so that's helpful, thank you. Somebody's just latterly put in the chat around, they're a bit confused about who's creating the SPC and Pareto charts that you've been displaying, both yourselves and Lee. Are we doing that as ESIST, as in you're doing that, or should organisations and systems be aiming to do that for themselves?
Yeah, great point. And I think what we're trying to do through this, and I've had several calls with people this week, is avoiding duplication of effort. And so I am in, well, some would call it a privileged position, some people wouldn't, in terms of that I have access to all of the national data. And so therefore I have the ability to create a dashboard, to create a data visualization in a way in which would be beneficial to a lot of other people. And so what we want to avoid doing is, say, for example, every trust in the country is trying to create a dashboard similar to the one that we have now. That seems an incredibly pointless duplication of effort. So therefore, if they do want access to this, please get in contact with me. And equally, if they come up with any different ways in which they would like to present the data, or any ways in which they see it might be benefited on the dashboard, then I'm more than happy to take any questions, comments, points of view on that as well.
Great, thank you. So there's also some discussion around the competing reporting demands and data requests, and just a comment really, and whether or not you might be able to answer whether or not there's, you know, of anywhere that's been doing this really well without becoming so overwhelmed.
Yeah, I mean, Lee might have a comment on this, and this is something which is a very hot topic at the moment. So we were acutely aware that when this new data collection came out, so obviously if we go back to kind of this time last year, you had the DPTL, the Discharge Patient Tracking List, that was kind of colloquially called, and that was on a weekly basis, and that was kind of met with a bit of pushback from people, I think, you know, quite rightly, because, you know, that was a lot of data to try and collect. And then obviously during this period, we've gone now to a daily collection, and obviously there's now two parts to it. So there's some parts that are daily, and then there are two new questions which are weekly. The balance is that in order to make strategic decisions, you do need a level of granularity that helps you answer questions. So if, for example, as I talked about earlier, is if we just looked at raw numbers, if we just said the level is X, can you make a decision upon where you should focus some of your resources? I think a lot of people would argue that you can't. You could to a certain point, but I don't think you could answer all of those questions. But because the new collections go down to such a granularity so that we can understand out of the 100 patients, for example, that 20 go here, 30 go there, 10 go there, etc., and this is what they're waiting in hospital for, that's when you can start to make targeted interventions and start to have a look at improvement methodology. So although we know it's an issue regarding data burden, and that has been referred, the collection has been referred to the data burden national team, we don't believe that is going to change anytime soon. So although it's a significant challenge, we do continue to thank the organisations for the amount of time and effort they're putting into this.
Thanks, Chris. And just the one lastly for you, is there any discussion or any readmission data that is being looked at or collected just with regards to consequences, potential consequences?
Yeah, a fantastic question. That is something that has been earmarked. The challenge around so looking back in terms of readmissions is something that will probably be picked up next year. Or in the early stages of 2021. The reason for that is because you have to allow a certain period of time so that you can get kind of a baseline position, and you can understand exactly what the question that is being asked. So in terms of readmissions, but I don't think the question, if you broaden it out wider than just readmissions. We also then want to have a look at harm for patients. We also want to have a look at different pathways that patients have gone that they historically might not have done, and what issues that has then presented. So a list of questions has been written up, and during next year they will be answered and published.
Lovely. And then this question is probably for Chris and the panel, actually, and this is around when and if the dashboards will be made available to local authorities. Any ideas or thoughts?
Drop me an email. Drop me an email, and I can go on distribution list. There is no. This data is freely available. We don't have any issues with sharing it.
Okay.
Unless anyone else on the panel disagrees.
No, I think there was some consideration around some of the discharge sit rep data. But again, similar, if we drop an email, I think there is something around. I think it's links to another question that's just popped up around system improvement. A lot of discharge policy cannot be done by health alone. We need to work as a system, and so joining up some of this is really important. If there's data we can't get hold of or can't get access to, then we'll try and work that through. But I think this has been raised in the work plans to try and widen the list, and so if we can't remedy it, we'll take that away and see what we can do.
Lovely, thank you. Something's just popped up in the. I think I'll ask this question first. So this has just come through. Actually, has the list of questions been co-produced with local authority colleagues?
I'm not too sure. I've only been privy to it from one of the national cells that I sit on. I don't know where that list has come from, but I can certainly find out for people. I would imagine that it's not kind of an isolated group. I think it would be a system-wide, all-encompassing group.
Okay, so just moving on a little bit, being minded of time. Lee, this is for you. I think you may well have picked it up, and I think Callum, you may have picked it up as well, but I think it's probably worthwhile just reiterating about the explanation of some of the targets with regards to the specific question was around the 21.94% and that increasing. Just if you can explain that a little bit more, that would be helpful.
Yeah, apologies for that. So 21.94%. So this is the percentage of beds occupied by people experiencing a long length of stay, and increasing just means that's rising on a within that system that was rising from the week before. I think the significance of that is we know the detriments that people experiencing a long length of stay or the detriment it has on a person around deconditioning, and just to reiterate that by staying in hospital for a longer time, is associated with larger levels of deconditioning, which is then going to need increased levels of support on discharge into the community through increased dependency, needing increased beds, QDS double up packages of care, etc., etc. So we sort of try within NHS. I suppose it's used as a bit of a surrogate of surrogate measure of a level of deconditioning, and important to understand what's happening, because a lot of the reasons for that 21-day length of stay are within the acute hospital's control. Some aren't, some are without, but it's around just turning the making sure we're looking at ourselves before looking externally.
Great, thanks, Lee. And another one here, would access to ancillary services make discharges over a 7-day working week be more successful? And I think we probably all know the answer to that. But the other bit is this included in the work? Because I think there's some organisations and systems that recognise that, but haven't necessarily got the data to show it.
Yeah, so I completely agree. I think there are a certain amount of core services that do need to be working 7 days to support this. Talking to a system earlier in the week, they have a massive challenge accessing any equipment services on a Saturday and Sunday, which does have a massive issue. It's always a balancing act, I think, with these things around trying, well, what do we need versus the data burden from a central perspective, and I think that's always in the back of our mind. There's the community service data set that are coming online later this year, early next year, which I hope will pick up some of this. Is not going to be perfect, And I think there is something around local systems, and it comes back down to sharing data across the system. All of this data is available within local systems, and so having that local systems working is absolutely vital to underpin all of this. And I think I can't really state the importance of those honest, open and trusting relationships at a system level to be able to share some of this data. Trying to put it all nationally, trying to get through the various hoops nationally is quite a challenge for every partner within the system. Whereas locally, if you're doing it around service improvement, it is a lot easier to share some of that data, which slightly sidesteps the question. But I think there is work going on nationally, but there's also not to downplay the importance of that local data information sharing and trust in being able to use this for service improvement.
Lovely, thank you. And I think opening these to the panel also, we heard from John Bolton in one of the webinars that we've just recently been working with, and one of the questions here is, do you have the tools, or are there any tools that compare discharge destination to the John Bolton model?
That's a good question. I believe we do. The work just not been undertaken. So I think that's certainly something that we should probably discuss on the National Discharge cell. Because as great as that piece of work is, what we want to better identify is there any variation for a particular organisation or a particular system.
Sure. Okay, thanks.
So that's certainly something that we can get back to people on.
Okay, thanks, Chris. And again, for yourselves and the panel, are there any good examples of good data collection and analysis that is driving service design from the community and local authority in pathway 1 and 2 services?
So I think, I know we keep going back to last week's webinar, but I think Oxfordshire were a great example where they were starting using some of their data to drive some of that improvement and had a really, really good handle on their data as a system. I think Frimley are beginning to use their data as a system to start informing how they're doing and what they're doing. Be interested to hear from other panelists to see if they have any other suggestions.
Okay.
Yeah,
I
think Lee, I think that's it. I think it's great to kind of hear about organisations that have got good quality data. I've been working with two very different parts of the country around this particular topic. The challenge that they face is that they understand what it is they want to do, so they understand what the ask is, and for their ask, they actually kind of want to use their historical data to forecast what they think might happen over the next 3 to 6 months. The challenge that they face, and I'll kind of apply it to 2 different areas. So in the acute setting, you've got data coming out of your ears, right? You ask for whatever you want, you've got it. The challenge is that if you then start to have a look at external from the acute settings, actually data is a little bit harder to get. And I think there's significant variation in one organisation to another. So these 2 organisations that I'm currently working with, they are really struggling to get any type of historical data. So they might have data for the past kind of 3 months, but you can't really use any type of forecasting for 3 months because you need to have a look at seasonality and much more historical context. So I think what we could try and do is try and get organisations that have not necessarily cracked it, but have got good data and are doing something with it, and we could almost kind of hold them up as good practice.
Great, thanks. And Rosie, is there anything that you'd like to add to that?
So very keen to share good practice locally. I'm very happy to facilitate where we can from the Better Care Fund sort of side of things. I did also just want to come back to some of the earlier conversations about the data and how it's available and so on. There are obviously still challenges. This is all new data sets about how we can put that to a local authority footprint, and so those are things that we're still sort of discussing and trying to work through, because clearly, as Lee has said, this is about local systems working together, and it has to be about them being able to work together using data effectively. So those are things we're working on, and then as Chris has mentioned, there's further work going on around a sort of wider set of discharge metrics that might, for example, include the readmissions issues, but also other things as well, effectiveness of reablement, for example, and those sorts of things are under discussion as a sort of wider set of information and data that we're going to be wanting to be able to be available both locally, regionally and nationally, in terms of how systems are doing on discharge, and so that you can be driving improvement from that perspective and understanding that wider picture. So there's a lot of development work still going on, and we're very open to local systems letting us know what they think the right things to be including in that are. We can't necessarily promise to be able to deliver it, but that's what we'd hope to be able to do.
Great, thank you. Just a last couple of questions, I think, if that's okay. First one is around how can you accurately measure the proportion of discharges through pathways 0 to 3? And does all the data sit with the acute hospital trusts, and are they expected to submit this data currently?
Regarding data submission, I'm not aware of any collections around that. Lee, do you know of anywhere?
So I think there was an appetite to try and do this. I'll probably need to pick up exactly where where that has got to. I think on the discharge sit rep, there's home care home, which gives an indication of the number of people who've got back home versus new care placements. But there is home obviously follows the NHS dictionary definition, so from a care home back to a care home would also be captured under home in this one, so it doesn't necessarily do everything people want it to do. So it does. So I suppose it does, to a certain extent, it does sit with the acute in the fact that it sits with the SIT rep itself. But again, one would hope as a system you would sort of be able to understand and share that data. You'd hope the single coordinator or the single point of access has a level of information around pathway 1 to 3. May not necessarily have a pathway 0, but which should have pathway 1 to 3 data. And between the different partners within the system, this data should be around locally. We know it's not perfect, but I think we will try and find out where that piece of work has gone to around trying to understand the pathway 0, 1, 2 and 3. So I know that was in train, but again it comes back down to the data burden, and I think there's not a massive appetite at the moment to do more data collection than is absolutely necessary.
Sure, thank you. And I'm just going to finish off really just with one of the comments, which is around can you highlight where good practice is? So you mentioned Oxford earlier. That might be helpful if we could provide the link from the previous webinar when they were talking, just so that people have got contact details to be able to get in touch. So Callum, I think that's it from the chat room. So coming back to you.
Thank you very much, Helen, and thank you to Lee and Chris and the panel for sharing their knowledge and experiences. Just so you know, we have provided the links here on the slide for the further 4 webinars happening across the next 2 weeks on Tuesdays and Thursdays, 11 to 12. So please encourage you to join those. Next slide, please. We also have our ESIS Futures platform. So if you look on the bottom left-hand box, it says join the ESIS network. If you click on there, it'll take you to a hyperlink so that you can join the network. There's plenty of information, guidance, good practice, ability to share, get in contact with each other, which is really fantastic space. And I know there's lots of futures platforms out there, but we've worked really hard at developing ours at ESIS. Next slide, please. And I suppose the biggest thing we were trying to do is we work together nationally. So the Better Care Fund team, LGA and ourselves across NHS E&I really want to provide as much support as we can, especially during this difficult time as we head up towards the end of the year and Christmas. We appreciate that the COVID numbers are going up and you're probably struggling to do lots of improvement, but we are here to support. So if you need any help and support, please use the links that are there. It can be small pieces of improvement or it can be larger pieces for whole systems across health and social care. So please do get in touch. And what we've tried to do is, in order to make each webinar better, we've put out a survey that will come to all participants with the slides. So if you have just a couple of minutes to share that feedback, that'd be fantastic. Obviously, over the next few months, there might be more webinars coming out, and certainly the Ageing Well and Communities team will be picking up after we leave at the end of November. So any feedback would be gratefully received. And so, yeah, a huge big thank you. If you have any questions, obviously we will try and we're going to collate all the questions from all 7 webinars into an FAQ document. We've already got FAQs from our first lot of webinars that came out earlier in the year, and hopefully we'll get that published soon. But if you have any specific questions relating to discharge to assess, please email england.d2a@nhs.net and they'll do their best to answer as quickly as possible and provide you with any information. You can also access, along with the ESIS platform, you can access the Better Care Exchange, so you can email the Better Care Fund team at the addresses you can see on the bottom right of your screen. And again, for all the speakers and presenters today, thank you for your time, but more importantly, thank you for coming to join us. I know you're all very busy doing your day jobs, and we're here to support as best as we can. So thank you again for your time.